Hi, welcome to the Emerging Therapies Stakeholder Meeting. This meeting is being recorded, so please state your name and the company or organization you're affiliated with each time you speak. This is Lita Vasquez. I am with the Healthcare Authority Prescription Drug Program. Today, Dr. Judy Zerzan and Mike Bonetto are going to present a summary of the Emerging Therapies Workgroup topics and discussions. Then we will open it up to the meeting participants for questions and comments. To speak, please use the raise hand function and I will unmute you. You can also ask questions through the question box and I will read them to the group. Now I will turn it over to Judy and Mike.
Great. Good morning, everybody, and thanks for joining. We're going to go over a summary of our meeting and then review the ideas that we discussed as that might be going, it would be possibilities for going forward. So next slide, Lita. So as you may remember, this work group was charged with helping HCA identify concerns, ethics, ideas, perspectives around emerging therapies. And the work group members were appointed by HCA and included representatives from a variety of medical fields, managed care organizations, and patient advocacy organizations. And some of the issues that we discussed included long-term funding, quality oversight and outcome tracking, management of patients that are eligible for these emerging therapies, potential improvements to health outcomes and quality of life as a result of these therapies, potential long-term savings or expenditures to the state, and metrics that could be used to measure the fiscal and health impacts. Next. So this was our meeting schedule. We had a variety of invitation only and open public meetings as we went, and we covered a broad variety of topics and had discussion on Medicaid, the private sector, patient decision aids and patient experience, funding options, outcomes, quality of life. And so we are today in this final meeting where we'll summarize the work group's meeting topics and discussions and stakeholder questions and comments. Next. So here's a recap of the work group topics. So we started giving an overview of sort of what are emerging therapies and what are specialty drugs. And specialty drugs are sort of these medications that are for often more rare diseases, a very specialized patient population. And about 10 years ago, specialty medications accounted for about a quarter of total pharmacy spending. And today they contribute to almost half of pharmacy spending, but only about 2% of prescriptions. Next. And we talked some about there's a robust pipeline of these specialty drugs in development that often are really breakthrough drugs that are either perhaps curing or making a significant change to people's disease state. And some of these specialty drugs that we talked about include certain types of cancer, cystic fibrosis, Duchenne muscular dystrophy, spinal muscular atrophy, non-alcoholic steatohepatitis, which is less rare, but there are a few drugs in that pipeline, blindness, hemophilia, Alzheimer's, and a few other rare neurologic diseases. Next. And of the drugs now that are in phase 3 trials, so that means getting close to getting FDA approval and coming onto the market, 60% are specialty drugs, a third are orphan drugs, 13% are considered breakthrough therapies, and only about 8% are biosimilars, which is a way to have kind of a generic type of drug for some of these specialty drugs that because of the unique manufacturing process and how to make these drugs, the term generic doesn't quite fit, but a biosimilar is what's similar to that. And of the applications submitted to the FDA, about 25% of new drug applications has been granted priority review. And this is sort of what we think about in these emerging therapy drugs, that they are really novel and have a unique contribution. Next. So we discussed in some of the work groups the current approaches to determining coverage, and there are similarities, not surprisingly, between commercial insurers and the Washington Healthcare Authority in terms of how evidence is evaluated, looking at the budget and fiscal impact analysis, developing clinical criteria, and tracking outcomes. Next. And decisions in coverage and criteria are very complicated. We had some really good discussion about this, about how people have different perspectives and how the decision makers value a drug and think about it is really a web of interrelationships, including looking at the payer perspective, looking at society's perspective, looking at patients and caregivers' perspectives, and then the suppliers. And the decision-making criteria may be weighted or valued differently, sort of depending on your perspective. And it often comes to our job at the state to figure out what that bottom line is and how we decide. Next. So we spent one whole work group talking about cost, quality, and access, and thinking about what levers we have, other ideas, including reinsurance options with orphan drugs. Medicaid has something in federal regulation called best price, and that sometimes affects the manufacturer's ability to price certain drugs for everyone, and thinking about that with rebates. Thinking about the societal impact, particularly if these drugs allow people to go back to work or allow people to live to adulthood, sort of what happens that. There has been a fair bit of talk in Medicaid circles around outcome-based contracts. So thinking about, and there has been support for the federal government to try and figure out how this might work. So for example, with the hepatitis C drug, an example could be if someone is cured of hepatitis C, then Medicaid will pay a certain price. But if they have a treatment failure or not cured, then it would be a different price, or maybe no price at all. And so thinking about what outcomes could be. Another example is a drug for blindness. If you can see, and depending on how durable that is, you pay one price, and you pay a differential price if it is less successful. Also, we talked a fair bit about long-term side effects, and that many of these we don't know what those long-term side effects are, and wanting to be cautious. We also talked a fair bit about cure versus maintenance. So a cure might be a one-time treatment and then you don't have that disease anymore. An example of that might be sickle cell disease. There's some drugs in development that might take that away altogether. Versus maintenance, which might be a drug that relieves the symptoms of your condition, but you have to take that drug for the rest of your life. And we had some really good discussion about the patient perspective here and how that might vary disease by disease. On patient decision aids, HCA has been working on certifying and supporting patient decision aids for a few years now. In fact, I'll give a little plug. This Friday, we have a half-day patient decision aid summit. And we talked about this as a potentially one approach to this in helping people understand the potential risks and benefits of these new therapies and what that might look like so that a person can and their family can make the best decision for them. We talked some about outcome registries, particularly since some of these drugs are new or coming down the pipeline, very new, and wanting to be able to track what happens over time and looking at that. And so having some sort of registry or way of monitoring both the benefit and the side effects. We talked some about provider education and informed consent and how to best help prescribers both understand the risks and benefits of new drugs and help communicate those risks and benefits to patients and their families. And then we talked some about alternative treatments. Next. We also had another topic that we discussed as the ethical considerations for emerging therapies in thinking about payer policy decisions, personal patient decisions, medical necessity, the process of healthcare decision making, and talking about the benefits and harms of treatments. I think particularly some patients and families that have these rare, very severe diseases are very interested in having relief about that and knowing what the potential downsides are, whether it is that the treatment just doesn't work or if there are downsides that might be side effects that are different from the symptoms they're experiencing now. Figuring out sort of how to arrange that is an important topic to discuss. We also spent a fair bit of time talking about the state policy decisions and ethical considerations because there is a limited state budget and we don't have the funds, particularly in a downturn that we're in now from COVID, to pay for everything for everyone. And so how do we figure out how to make those right decisions and how to keep our society as healthy as it can be? Next. And I can't remember, Mike, is this where I was gonna pass off to you, or did we pass that already?
This is Lita. I think that was gonna be slide 15. So I can let you know, this is slide 12.
Okay, thanks. There are numbers, so I was like, wait, where do we go? So
yeah, I just realized that. Sorry.
You're doing great, Judy. Thanks.
Okay, thanks, Mike. So we talked about these 4 state strategies to balance some of this tension between access and cost because we don't have an unlimited budget. And we want to do the best for our population. And so some of that might be, there's sort of these 4 ways that states generally use to manage prescription drug benefits. The first is pharmacy benefit management. And so thinking about prior authorizations and having criteria and figuring out maybe the most cost-effective site to administer a drug. Second is multi-agency purchasing. Hepatitis C is an example of that, as HCA has created a contract that covers not only HCA covered lives, but also labor and industry and corrections. And so that's an example of sort of pooling lives over a number of different populations to perhaps get a better price. Third is alternative payment approaches. So thinking about what I mentioned earlier and thinking about how we might pay for something differently if there is a greater benefit than if not. And then finally, talking about affordability approaches. And so what other ways could we get a better price? Could we pool some of the risk? Doing reinsurance as various options to do that. Another example of the multi-agency purchasing that I think gets to affordability is some of vaccines, and that every payer can use a lower cost, a vaccine that has been purchased across payers and using that. And so I think figuring out sort of different ways to leverage some of that experience are things that we talked about. Next. So we had a lot of discussion about different funding options and questions that, you know, didn't always have a direct answer. So as an example, when are these alternative payment models appropriate? So when might we cover something with a differential price based on outcome, and how might we know that, especially when some outcomes might be further in the future, and other outcomes we might want to make sure that they are durable or that they last over time. Another question we talked about is when to carve it out of, for example, an MCO contract and pay for it separately, or when to leave it in. Discussions about the durability of response. So wanting to make sure that some of these drugs may be a cure over a lifetime, and others could potentially wear off, and what happens if that happens. We talked some about different ways of paying for drugs to sort of spread out the cost, including stop loss provisions or reinsurance, or paying over time. One of the examples was about how you make car payments, and you make car payments over time, and whether that could be something that would work here. I think one of the things that makes that a little more challenging is that people often change types of insurance, and so so who pays for that over time if insurance changes? We talked about outcome-based models. And strangely, we talked about a public health emergency far before COVID, and how that might change delivery of drugs, or how we might want to get drugs out quickly to a small or large population. We talked about discounts and revenue caps. An example of this is France, that their government sets a maximum amount of revenue that a drug company can make. And so while that isn't under a state's purview here, that's more of a federal solution, could be something here. We talked about coverage based on evidence development, which is something that Medicare has done in the past. I think one of the first places where Medicare did this was on lung reduction surgery for emphysema. And so the idea is that you cover it, and then you collect the evidence as about whether it works or not, and then make a coverage decision based on that evidence that you've accumulated because you've paid for it. There's international price referencing. So every country is paying for these kinds of drugs and has different ways of doing that. And so is there a way that we sort of look at the price across different countries and pick a benchmark or an average in some way? We talked some about some of these opportunities, but also some of the challenges in implementing them, which a number of them have pretty significant challenges, and also the potential for unintended consequences. And so thinking about that. And we talked a fair bit about how often our reaction or how our coverage is somewhat reactionary, and that it's easy to look in the past and figure out how coverage worked or didn't, and whether you made a good decision or not, but it's much more difficult to look at future trends. And with these emerging therapies, it's much more important to think about what happens and what is that future, and that is perhaps more important than looking at the past for these drugs. We talked about making sure that the patient knows the framework and understands some of these issues. And then we also talked about the potential for like a rare disease pool where money would be pooled and then could pay for these therapies across payers. Next.
And Judy, this next slide will be your last.
Excellent.
And it's just taking a little lag when I switch slides here. There we go.
Okie doke. So we talked about some different ways of doing alternative purchasing models. And one way could be financial based and looking at funding either by the patient level or the population level. And if looking at the patient level, could think about either utilization caps or a manufacturer funded treatment initiation. And then after that, continuation by the state or the payer. And thinking about the population financial based model, either a price volume agreement or some sort of market share, particularly if there's competition in multiple drugs by different manufacturers. And thinking about alternative purchasing models that are health outcome based. There are two of these. One is conditional coverage and one is performance based. So conditional coverage could be something like the coverage with evidence development. So it's covered, but we collect outcomes. And as our experience grows, decide whether to continue coverage of that drug or not. Or another option under this is conditional treatment continuation. So looking at the person's experience and whether their disease is treated or not, and if it is not getting the result that's expected, then stopping coverage for that drug, because maybe it's either not working or it's not working as well as expected. Looking at performance-based options under health outcome-based areas, we could look at an outcomes guarantee. So for example, the drug that can stop blindness from a genetic condition, guaranteeing that that will work over the lifetime of a person, or guaranteeing that that result will work maybe over 10 years or some set period of time. And then also performance-based, looking at the pattern or process of care and how that's delivered and how the disease of the person goes through its evolution or doesn't based on this drug. And now I will turn it over to Mike.
Thanks, Judy. And for whatever reason, I'm getting some bandwidth issues, so I'm not going to have my video on. I think it'll might be easier. But that was a nice summary of a year and a half worth of work there. I'm going to go through a few slides and then hit kind of these key kind of work group recommendations and themes at the end, and then we can open it up for some Q&A. We have another kind of Venn diagram up here. I know Judy had one up earlier, but this one was adopted by the CDC a while back, and just showing kind of this framework for using evidence in decision making. And I think, the point of this is just showing you that there are all of these other factors that go into it. So we think about really just using best evidence, but really we have to look at what's the population characteristics, what are those resources, and then even more importantly, and on the outside of that, what is kind of this environmental organizational context? What's the political environment? What's the budgetary environment to really kind of think through all of these big decisions, specifically now when you think about some of these breakthrough drugs. Next slide, Lita. Thanks. And this piece Judy hit on, but I think this really got highlighted in several of our meetings, that when you think about these breakthrough drugs coming at a pace where they're not necessarily going through kind of the traditional evidence review process. So really the FDA has kind of expedited this this pipeline, which has made that decision-making process that much more difficult. So that really it's, what happens when interventions come into practice without sufficient evidence. And so this is, a lot of discussion around, okay, how could HCA look at doing things differently? Some stats that were given out were pretty remarkable, that the proportion of approvals supported by the FDA approvals, supported by at least 2 kind of pivotal trials, decreased from 80% in 1995-97 to 53% in 2015-17, while that average trial size didn't change at all. So it just kind of goes to show you're kind of getting pushed into an area where you have to make these decisions without all of the evidence that you are used to. So this is significant, and as you kind of look at those bullets there, I think Judy touched on some: conditional continuation coverage, negotiate best price on volume or exclusivity, negotiate best price on outcomes, and require data for coverage. The data piece is significant just because if we're losing data on the trials, how do we get data as the drug kind of enters the market? And I think there's just more work to be done on that. Lita, next one, thanks. So tracking outcomes of emerging therapies. So that the question now becomes, okay, if we know that there's a limited amount of evidence and research that's been done, we know that kind of randomized trials are the gold standard, but we don't necessarily have that at our fingertips all the time. And even when they are, they're performed with this narrow population under strict management conditions, which doesn't necessarily translate well into the real world. So we're really trying to kind of figure out what's the best platform then that the state can take that on. So that, as Judy mentioned, the data registries and quality improvement programs can fill this gap. So we're really trying to figure out what's the best way as again, more of these breakthrough drugs come to the market. Can there be systems in place to capture that data so we can really monitor that progress moving forward? One thing that was highlighted was that last bullet, this step wedge or trials could be conducted in the context of a quality collaborative like the OB program and the care outcomes assessment programs. And that really is an intriguing model to look at, where you've got 30,000 births annually, over 200,000 in this database, 20 hospitals, Washington, Montana, of kind of all levels of maternal neonatal care, and all of that data really has helped them kind of better inform, use of steroids for at-risk preterm births and elective induction of labor at certain time intervals. So all of that is just, again, better evidence around how the state could be better informed and put some systems in place to move forward. Last one, thanks, Lita. So again, out of all of that discussion and all those summaries that you heard Judy walk through, really there are three big themes and buckets of kind of recommendations. And I want to preface this because, the recommendations almost came into some sort of almost question form that there's more work for HCA to look at. But these were kind of these big buckets of kind of recommendations or themes that came out of it. You heard Judy mentioned the patient perspective and the patient decision aids and what, she's just kind of rolling something out this week. But there was a lot of dialogue between patient advocacy groups and physicians around this need to understand the risks and benefits. And so, where can HCA kind of play that role when you're going to have a continuation of these breakthrough drugs kind of hit the market? At the same time, not only from the patient side, but also from that provider side with both informed consent and then, provider education of understanding those risks and benefits. So that really, I think, was kind of first and foremost of how do we better engage patients to understand kind of their options and their risks and benefits before they engage in some of these treatments. The second was measurement for health impact. And this is what we've kind of talked about at length here of just, what do you do without all of this sufficient evidence? So I think this is where the outcome registry, I think, took a higher level of importance during these discussions so that you can really start to monitor, cure versus maintenance and long-term side effects. And, how HCA, goes about that. I think there are still questions that they are going to be looking at in terms of, what is the right approach to develop some of these registries. And then lastly, Judy had that long list of kind of funding options or state payment options. And this is, again, when you have limited evidence, what is the right approach? When there could be a cure, but we're not exactly long-term effects, I think there's a sequential way to start looking at this. And, there was a lot of discussion around what Judy mentioned with the Medicare, the coverage based on evidence development. But there's also, how do we make sure that we don't break the bank, the state budget? And, are there options to look at stop loss or reinsurance options? Are there ways to look at outcome-based contracts that we can actually hold a manufacturer accountable for those, for the drug's performance? So I think, again, when I look at this recommendation, there is still work to be done to understand kind of where is going to be the best fit for certain drugs. But I think there is a lot that came out of those discussions to understand, there are many different levers, and I think some of those levers can get pulled differently depending on what emerging drug you're really starting to look at. But I think it was a helpful dialogue to understand there's kind of this laundry list of tools when we start to look at funding options or state payment options that HCA is going to continue to be looking at. So again, I want to frame that in a way that the work group really came at this to say, here are some of the important things that HCA really should be considering moving forward under these circumstances. And Lita, I'll wrap there.
Thank you, Mike. I'm going to start with a pre-submitted question from Danielle Walters from Bluebird Bio. She asks, is HCA considering utilizing their current value-based SRA template to execute outcome-based contracts for individual products / emerging therapies? If so, what types of products or classes would be considered for contracting, and would those contracts also apply to utilization in MCOs? There's a second part of this question, but I'll pause there.
Great, thanks, Lita. And I think Donna Sullivan, our Chief Pharmacy Officer, is also on, and I think the three of us will sort of tag team these, but maybe Donna, do you want to take this one?
Sure. We do have our value-based contract template approved by CMS, and so it is, we are able to use it for outcomes-based contracting. And so really, any product that that would come to market, we could use an outcomes-based contract on. What we're really looking for in those types of agreements are something that are meaningful contracts where the manufacturer is actually putting real risk on the table for the outcomes that we're agreeing upon. So we haven't signed any additional contracts beyond our hepatitis C contract right now. Most of the outcomes-based agreements that I've seen probably aren't worth, the juice isn't worth the squeeze when it comes to the amount of tracking and data collection and analytics and the cost compared to the potential outcome. So we would welcome any proposals from manufacturers on these products, but we will be looking for meaningful outcomes, clinically meaningful outcomes, as well as real risk, shared risk from manufacturers on the table.
Great. And the second part of this question is, would HCA consider revising its SRA template similar to what was just approved for Texas to allow for outcomes-based contracts that may span multiple years to assess longer-term efficacy of the contracted product / therapy?
And hi, this is Donna again. I'm not familiar with what Texas had approved. I don't know how it differs from what our template that was approved, but there's nothing in our contract that restricts it to a single year. So I'm not sure I understand the question.
Okay, Danielle, I will unmute you so you could follow up.
Hi, are you there? Can you hear me?
Yes. Yes.
Oh, great. I just brought that up just because the language in the Texas, the recently approved Texas SRA does appear to provide the framework for that. But if you believe your current template already accomplishes that, it was a different iteration than many of the templates, including Washington's, had. So that's why we asked the question. But
Okay, thank you.
thank you. Yeah, thank you.
And anybody else, if you can use the raise hand function if you have a question or comment. Okay, I'm not seeing any raised hands, and I'm not seeing questions in the question box. Oh, okay, here we have one. Here is Brian Warren. I'm going to unmute you.
Hi, can you hear me now?
Yes.
Okay. Thank you for today's presentation. Again, this is Brian Warren. I'm with the Biotechnology Innovation Organization. I don't have a whole lot of new comments. I think today was, a good summary of what has happened thus far. I think it will remain to be seen what actions come from the work group's discussions. And we hope that, as we've expressed throughout this process, that as HCA moves forward with any types of action items, that you will work collaboratively. We do want manufacturers of these emerging therapies do want to work with you to ensure that patients are able to access the medicines. So just we want to express our continued interest in working with you collaboratively on solutions to ensure that we have a system that can sustain patient access for these transformative therapies. Thank you.
Thanks. This is Judy, and that sounds great. I think one of the things we really learned was that this is all pretty complicated, and maybe we knew that before, but I think there aren't any easy answers here. And so I do appreciate the working together to try and solve this.
And next is Mark Cummings. Go ahead, Mark. Yes.
Yeah, Mark Cummings with Life Science Washington. It's a little hard to give reaction recommendations since we didn't kind of get to that level, but let me try to give some observations over the process and some areas of we can maybe work on. Obviously the work group, as we just heard, covered a ton of great content over the last year. I'd point out that sort of given the novelty and complexity of the issues associated with particularly the newer class of emerging therapies, I think that dialogue would have been stronger with some of the companies that are working on these if they had been at the table. They've obviously, in many cases, have been working on these issues for years, in some cases, decades, and not just at the state level, but at the federal level as well, which came up in a couple of the meetings as areas where more work needed to be done. I think including them would have been helpful. A few observations, just looking back over the comments from the last several meetings. I'd sort of point out that I think at times the discussion wandered or sort of bounced back and forth between a variety of issues. Sometimes total cost of drugs, sometimes specialty drugs, orphan drugs, price increases of traditional drugs, and then where we thought we were primarily trying to focus was really those issues related to this emerging class of emerging therapies that are really quite different than issues related to some of those other areas. So to us, I think it's important to separate those issues out. What you need to do to think about a new cell or gene therapy that hasn't come to market yet, that is a potentially one-time curative versus a maintenance drug, is very different than a specialty drug that has been in the pharmacy for 5, 8, 10 years. And sometimes when you guys presented data, we were using data from specialty drugs and transferring that to other classes. And then even within the area of specialty, we'd point out that the issues related to an emerging therapy for a rare disease with a very small patient population, and emerging therapies are applicable to broader patient populations. For example, a CAR T for cancer are going to be, the issues are going to be different. They're going to be priced differently and utilized differently. And you can't, I think at times the numbers were looking at a rare patient population, gene therapy, and extrapolating those costs across to other areas, probably wasn't, wouldn't hold in many cases. Those need to be thought through, and each of those cases differently. To that end, we sort of asked if the HCA had thought about, or do you guys know the total number of Medicaid clients that have actually received gene therapy or CAR T therapy at this point? And has the HCA done any modeling to think about or to better understand the likely patient populations for some of those therapies that aren't in the market today, but are anticipated over the next few years? Likewise, a number, then as the conversation moved on to other areas, we talked through innovative payment models, which I think you just summarize those, ranging from smoothing the cost curve for one-time potentially curative therapies, models ranging from outcome-based to pay over time, even at-risk contracting. Likewise, we thought it was great to have a really good discussion around the need to monitor the effectiveness and durability of these therapies over time. And again, to that point, those issues are really as important to the companies that are developing these therapies as they are to the HCA. And we would sort of ask does the HCA have a process for engaging in those important and complicated issues going forward as we think about both contracting, durability, and monitoring? Finally, I'd also point out that there's a long conversation around the HCA's new innovative contacts related to Hep C drugs, which have many similar traits, not exactly the same, but similar traits to some of these emerging therapies. And we would just sort of point out that when the Hep C drugs first came out, there was a similar discussion that these were going to be completely unaffordable, was going to break the system, and what were we going to do? And that really, in just 2 to 3 years, those drugs went from drugs that were talking about bankrupting the system to some of the HC is offering almost universally under an innovative, cost-effective contract. And we think similar innovations are possible, indeed likely necessary, to support the utilization of emerging therapies. But those are only possible if there's a sincere dialogue with the companies that are developing those therapies. Given the work group didn't really come to a set of formal recommendations, really just buckets of topics, we assume that more work needs to be done before any legislative or policy recommendations would be developed. So we'd sort of just ask what the next steps are and how you plan to work with industry to work through and sort through those issues.
There's a lot of questions. I appreciate your thoughts. I think this is an area we'll need to continue to work on, as you said, and it is complicated. And there isn't, I think, it is probably a drug by drug approach because there are so many differences. And so we'll need to figure that out. We do have a pharmacist that is monitoring the pipeline and looking at these drugs as they move forward and what the evidence is on safety and effectiveness and what things look like so that we're ready. But that being said, there is plenty of work here. I think COVID has put put the brakes on this work group a fair bit and focused our attention other places, but I think there is for sure more to go. I don't know, Donna, do you want to add anything to that?
I think you did a good summary. It is really hard looking at trying to evaluate and do models on the pipeline when we don't know what the drug costs are. So that has been a challenge. We can only estimate, that the prices for drugs that are coming out now will be those in the pipeline will have similar or even higher prices depending on the type of therapy. If it's a one-time gene therapy versus a multiple, like more of a maintenance treatment. So we are working on that. We do have a pharmacist. We look at the pipeline. We do try to carve, those high-cost drugs out of the managed care plans to make sure that policies are being applied, first consistently, but as well as making sure that the plans, they might have if it's a rare condition, we don't want to have certain plans, disadvantage if they have 1 or 2 patients with a rare disease that has an expensive treatment where the other plans may not. So we're looking at those, and then we're always continuing trying to look at policy development as these drugs are coming out to make sure that the people that need them are getting access to the medications. You asked a question about the number of clients that's received gene therapy or CAR T. I'm not sure how many CAR T patients we've had. I don't think there's been a lot. I will just say that with the cancer treatments, at least not in the Medicaid program, and those are carved out, so they come through. The approvals do come through my unit. And gene therapies, we've received 1 or 2, I think, requests for gene therapies, and they have been approved. So there's I don't know to what extent the information, there's very small numbers of patients, so it's really hard to share based on the privacy information and privacy of those patients as well.
Okay, next we have a comment from Matt DeGoyer, who is with the Lupus Foundation of America. He said, there are 2 new therapies that are expected for lupus nephritis in 2021. It is critical that coverage policies allow patient access to therapies that reduce cost and save and improve lives. Thank you. Okay, and I don't see any other raised hands. Does anyone else have a question or a comment? Okay, well, with that, Judy, do you want to close?
Sure, thanks, Lita. Thank you all for joining us. I want to particularly thank our work group members that spent a lot of time helping us think about this and provide their perspective, which was really helpful. And thank you all for your patience as we had to shift what we initially had planned for this work and planned for more in-person interactions, which is not the way of the world these days. But this is an issue that we will continue to grapple with as an agency. And we appreciate your help in thinking about that and as we move forward on this journey. So thank you all. Thank you also to Mike, who helped facilitate these questions. We really appreciated that. And have a great day.
All right, thank you, everyone.
Thanks, guys.
Thank you.